Hello, I'm Paneez Khoury, a clinician researcher who treats patients with rare eosinophilic disorders. Today we'll talk about two rare conditions involving eosinophils, hypereosinophilic syndromes, or HES, and eosinophilic granulomatosis with polyangiitis, or EGPA. The goal of this talk is really not to make anyone an expert on every aspect of the diseases, but more to help patients and families know what to watch for, what questions to ask, and how to partner with their care team. So by the end of this presentation, I expect that patients and families will be able to describe the basic difference between HES and EGPA, including the role of eosinophils and why these conditions can affect multiple organs, to be able to recognize the symptoms and warning signs that should prompt medical attention, including any symptoms affecting the lungs, the sinus, skin involvement, nerve involvement, or even the heart and gastrointestinal tracts. And I think the real goal here is to be able to use practical self-advocacy strategies during medical visits, including tracking symptoms and eosinophil counts, to be able to know what to ask about in terms of organ involvement and understanding treatment goals and helping coordinate care across specialists. So our journey today will go through what eosinophils are, how they're involved in HES and EGPA, to discuss some of the symptoms and how people come to a diagnosis, to go into a little bit of detail about treatments and goals, as well as to cover some advocacy strategies. So why do eosinophils matter? And what are they? Eosinophils are white blood cells involved in allergy, asthma, inflammation, and parasitic defense. Some eosinophils are likely helpful in general tissue maintenance because they're found in normal conditions in some parts of the body, but too many in the blood or too many in certain tissues can really be a problem. So in HES and EGPA, eosinophils can become too many in the blood or be very active and release all their granules. This can contribute to tissue inflammation or organ damage. And in very severe cases, this can result in significant damage to organs such as the nerves, heart, kidneys, or blood vessels. And this is what we talk about when we say end organ damage. So eosinophils are really like a specialized response team. They're helpful in the right setting, but harmful if they show up in too many places or stay activated too long. So HES is not one single disease. It's a group of rare disorders where high eosinophil levels cause symptoms or organ injury. And the number we typically use is more than 1,500 per microliter in the blood. And when folks have really high eosinophil counts, this can lead to inflammation and damage or symptoms. And historically, this disease was considered to be very severe with an increased risk of major organ damage. And fortunately, while many patients do have chronic symptoms, earlier recognition and treatment, as well as targeted treatments, have improved the experience of the disease for many patients. And so really the types of conditions within the HES umbrella are many. There are familial forms, there's idiopathic forms when no cause is found, as well as myeloid conditions, which are more like primary bone marrow or blood disorders, as well as lymphocytic variant HES, where the T cells are felt to be part and parcel of the disease. So EGPA is also considered a rare disease. It is a rare form of vasculitis, meaning it causes inflammation of blood vessels. It's also associated with elevated eosinophils, and there's not an exact number that's used, but it can be in the same range as patients with hypereosinophilic syndrome. It often occurs in people who have pre-existing asthma that all of a sudden gets worse. Oftentimes patients have sinus disease or nasal polyps. It used to be called Church-Strauss syndrome, but the name is now eosinophilic granulomatosis with polyangiitis, which is EGPA. Like hypereosinophilic syndrome, it can involve many organs and cause lots of symptoms. But as I said previously, a common presentation is involvement of the airway, with then progressing to more pulmonary involvement, and patients can have rashes or numbness and tingling in the setting of neuropathy. So to summarize, symptoms of both HES and EGPA are myriad. They can range from rashes or itching, swelling in the skin, or hive-like lesions. EGPA tends to have something called purpura, which are really dark red lesions that occur in typically the lower legs. It doesn't always happen, but that can be one of the symptoms. In the lungs, symptoms of cough, shortness of breath, and wheezing can be common. Typically, these are in the context of asthma, but people can also present with something called eosinophilic pneumonia. In the gastrointestinal tract, patients can have abdominal pain, diarrhea, or nausea. And if they receive an endoscopy, sometimes they can be uncovered to have eosinophilic gastrointestinal disease or gastroparesis. In the heart, the symptoms are not really very specific to the heart, but patients have chest pain, arrhythmias, shortness of breath, palpitations, or lower extremity swelling or symptoms of heart failure. Those can be signs that the heart is involved. And then from a nerve perspective, initially symptoms could be numbness and tingling, and can progress to things like weakness or foot drop or wrist drop, where you can't really control the limbs, or in severe cases, clots can cause symptoms such as stroke. So essentially, the central issue is there's too many eosinophils, and when there's so many in the blood, they can cause organ damage. So let's keep this in mind as we move forward. And so one of the most common questions I get is, how do you distinguish between these conditions? How do they overlap, and how do they differ? And I will say that's a very difficult question. Both conditions can involve high eosinophils. As I mentioned before, both can affect multiple organs, including the same organs. Both of them can be delayed in terms of diagnosis and really require coordinated specialty care by a multidisciplinary team. But I show here some lines that demonstrate that eosinophilia underlines a lot of the symptoms involved in both conditions. And more typical of HES is persistent eosinophilic organ involvement that can have waxing and waning in terms of the symptoms. The symptoms can be chronic. And in contrast, I would say EGPA can be characterized by more specific flares that occur. The constellation of symptoms that they typically have are asthma, sinus disease, and nasal polyps. And in the more severe vasculitic phase, symptoms such as peripheral neuropathy, purpura, or kidney involvement can occur, particularly if patients have ANCA positivity, and ANCAs are an autoantibody that is involved in a subset of patients with EGPA. About 30 to 40% might have this antibody positive. For both HES and EGPA, there are some symptom patterns that might suggest either a new onset of a disease or worsening disease in the context of high eosinophils. And so, again, I will emphasize this is in the context of high eosinophils. Any symptoms such as persistent or worsening asthma, especially when symptoms were previously controlled, is a concern. If there's new or worsening sinus disease or nasal polyps in the context of high eosinophils, an unexplained rash, new swelling, fever, weight loss, or severe fatigue. A lot of patients have fatigue. Numbness, tingling, loss of muscle control, weakness, or shooting nerve pain, developing any chest pain symptoms, fainting, palpitations, shortness of breath, or leg swelling, as well as anything involving the gastrointestinal tract, such as severe abdominal pain, diarrhea, blood in the stools, and then any biochemical abnormalities such as blood tests involving the kidneys, or having blood or protein in the urine. But when in doubt, I think the best course of action is to reach out to physicians involved in your care. A false alarm is better than ignoring symptoms, and it does often take different specialists involved in your care to connect all the different dots. And I think one of the main complaints is that diagnosis takes time. And if you look at patients who are diagnosed with HES and EGPA, sometimes it's multiple years of symptoms or blood tests before someone receives an actual diagnosis. And so as a result, patients often feel like they're navigating a maze of individual symptoms. And I recently, for example, saw a patient who had seen multiple specialists, each focused only on their part of the picture. And, that's what you can do in a short visit. The ENT doctor looked at the nose and the sinuses and the throat. The pulmonologist looked at the lungs and the breathing tests. The cardiologist looked at the ultrasound of the heart and so on. And unfortunately, no one put the whole picture together. And so I tell my patients to encourage their doctors to speak to each other and bounce ideas off of each other in the limited time that they have, but that these diseases really take a whole team. Otherwise, it's really hard to make the connections that are required for a diagnosis. And so, the reason why it can take a while is because some of the symptoms are similar to very common conditions. So there are lots of patients that go to an allergist with asthma, allergies, eczema, or sinus or stomach problems. The other reason why diagnosis can take a long time is that it depends on when you're getting blood tests. The eosinophil counts can go up or down, and especially steroids can have an impact on the blood counts. So if a patient receives steroids for an asthma exacerbation for some reason, or they had an attack and they got some steroids, and then shortly after a blood test was done, you may not see elevated eosinophils. And again, as I said before, different specialists can see only one part of the picture, and so it is important for patients to advocate for themselves. So what tests might be part of the workup? The first question is, are eosinophils high and persistent? And to check that, obviously, you need a complete blood count with a differential also as part of that. We tend to look at the absolute eosinophil count, not just the percentage. And the second question is, are there effects from these high eosinophils? Is there organ involvement? And this is where a lot of that extra testing that we talked about comes into play. Getting testing to check the heart, such as an ultrasound of the heart. In some cases, if there are abnormalities on the ultrasound, we will recommend a cardiac MRI. The lung testing can range from pulmonary function tests to a pheno test to look at eosinophilic inflammation in the lung, or CAT scans of the chest and as well as kidney and liver labs. We often will get tests looking at protein or blood in the urine. And there may be other imaging or nerve evaluation depending on the symptoms, and in some cases a gastroenterologist will be involved to do an endoscopy or a colonoscopy where appropriate. And of course the skin is very visible, and a tissue biopsy can help make a diagnosis if there's a concern for another cause, which brings us to question 3. Is there another cause? And there are other things that cause hypereosinophilia, including reactions to medications, development of parasites, especially for people who are from a region where there may be helminth parasites or other parasites that cause blood eosinophilia. Allergies, typically not just allergic rhinitis, but some of the other atopic conditions such as atopic dermatitis or eosinophilic GI disease can certainly cause elevated eosinophils. And there are, of course, other reasons. There are some autoimmune conditions associated with eosinophilia. There are obviously some cancers or bone marrow conditions that are associated with blood eosinophilia. And so it is really our job to look for another cause before making a diagnosis of HES or EGPA. Which brings us to question 4, is this HES, EGPA, or another eosinophilic disorder? And so this is where we do some of that ancillary testing, looking for those ANCA antibodies, looking at some inflammatory markers such as ESR or CRP, looking at the imaging and the biopsy results very carefully for eosinophils, and getting specialist assessment. And so I think the important thing to know is that not every patient needs every single test. The testing should be guided by symptoms, exam findings, eosinophil levels, and organ risk assessment. As you know, I will say there are certain tests that might require a visit to a hematologist, oncologist, to look at whether there may be a bone marrow problem. But again, those are specialized tests that are required. So there are some now non-steroid biologic medications used in both HES and EGPA, and I will caveat this, that this is not for those patients who have a myeloid type of HES. And I'm just going to go quickly through the mechanism of action of each of these because they act a little bit differently, even though they both affect the eosinophil cell lines. So the way mepolizumab works is that it blocks the IL-5 that is in the blood or the tissues, and IL-5 is a particularly important cytokine that is almost like the food for eosinophils. It really helps eosinophils survive, to grow, and to survive. And so when you remove that source, the eosinophil levels go down. In benralizumab, the action is slightly different. The antibody depicted in blue binds the receptor on an eosinophil. It's almost like a code on the eosinophil, so it binds that. And because of the way the antibody is constructed, it really brings in natural killer cells to kill those eosinophils and cause death. And what happens then is when you cause death of the eosinophils, your eosinophil counts drop pretty quickly down to very low levels or zero. And so both of these drugs have been studied for HES and EGPA. They differ in terms of dosing and age range for each of them. There are also different doses for HES and EGPA than there is for asthma. So the dose is often either higher or more frequent. So just something to be aware of. There are other non-steroid immunosuppressive medications used in both HES and EGPA. They're slightly different just for historical reasons, but on the left you'll see some of the medications such as hydroxyurea, interferon alpha, imatinib, methotrexate, mycophenolate, mofetil, and cyclophosphamide. Where you see a check mark, these are medications that have typically been used in hypereosinophilic syndrome, and imatinib continues to be used for patients who have a myeloid type of HES where there is a mutation or a variant such as PDGFR-A or PDGFR-B. Hydroxy and interferon alpha are used some still. However, for patients who are able to get a biologic treatment and respond, that is oftentimes a better option. And then methotrexate, mycophenolate, and cyclophosphamide are used more commonly in patients with EGPA as a medication that helps keep a patient's disease under control or in remission. And so, although those can, in some cases, be used in hypereosinophilic syndrome, they're more commonly used in EGPA. So now we're going to go into treatment. The point here is that these are goals and not just the medications. So from a monitoring standpoint, our goals are really to lower eosinophil-driven inflammation to prevent or limit organ damage. Overall, there are some body system or organ-specific medication targeting. So our goals are to control asthma, the sinus, the skin, the GI or nerve symptoms. We also aim to track medication exposure and to limit those that are more harmful, such as reducing steroid exposure when possible, or monitoring the known side effects of steroids, so ensuring that patients are looking at the bone density, checking blood for development of prediabetes, and taking an approach to minimize those side effects. And then the other goal is to provide patient support, so just improve or maintain the quality of life of patients, as it's not just about treating the eosinophils, but also making sure that patients feel supported and improve. And so, when living with a rare disease, it's important to monitor exacerbations and identify flares. This might require that patients have ongoing periodic monitoring of laboratory tests, even when they feel better. And those can often be spaced out to less frequent laboratory tests, depending on how things are going. We recognize that steroids are an important tool in both HES and EGPA. And even if patients are on therapies like biologics, sometimes steroid bursts will still be required. And so patients and families should carry emergency treatment when traveling, especially abroad and or away from their usual care system, so that if there's a reason to treat, that they can contact our care team and start treatment immediately if needed. And along those lines, having an emergency plan, knowing who to contact and what to do when things aren't going well is important. And either referring to that emergency plan or calling and reaching out to their doctors. It is better to reach out rather than wait. And if medications are running out, also reaching out to your care team so that they can help. So the right team depends on which organs are involved, and the most important thing is having doctors and other health providers who are responsive and are accustomed to coordinating the whole picture. And so this can involve allergist immunologists, rheumatologists, hematologists, pulmonologists, ENT doctors, and so on. And so sometimes a social worker or therapist may also be involved just to help with some of the other symptoms and outcomes from carrying a rare disease. And so the key takeaway is really important to advocate for communication between the different specialists and ensuring that the patient remains at the center of all of this and not feel like they're just bouncing around. So it's a little acronym that I came up with to help advocate for yourself if you're a patient with one of these diseases. And the T stands for tracking symptoms and eosinophil counts. And so when you get a hematology test or CBC with differential, making sure that you look at the absolute eosinophil count. So in this case, it's 1.05, and so that's about 1,000 in terms of the eosinophil count. The next thing is to report organ-specific symptoms clearly, and we talked about that in my previous slide, but reporting the specific symptoms. So say, that you have numbness in your foot, not just that you feel worse. And then the A is to ask questions about next steps and treatment plans. So asking, what makes this more likely to be HES or EGPA, and assuring that you do that. And then for the C, is really the coordination piece. And sometimes the patients are actually the center of this, ensuring that they bring their labs, the imaging reports, things that they might have had done at another specialist to their visit, tracking the medication history, the start and the stop of medications, as we often use that in line with the blood tests to identify whether medications are working. And if you have prior eosinophil counts, bringing those also. And then lastly, the K is knowing when symptoms are urgent and who to contact and when to seek care. So again, advocating for yourself using this track approach can be very helpful. And remember that you're an important part of your care team. Your questions and what you report help your doctor see the full picture and help make good decisions with you about your care. And so, I view this as a partnership between clinicians and patients on treatment choices, thinking about the benefits and risks of treatments, and asking your doctors, what are the benefits of this treatment? What are the potential side effects? How will we know if treatment is working? And also asking about potential side effects that you should watch for. And lastly, in some places there may not be a lot of doctors that are experienced with these diseases, and so asking about clinical trials, patient registries, or other centers where there may be some expertise can be useful as a patient. And so for my take-home messages, I really want you to take away that eosinophils can cause real organ injury, that symptoms should not be dismissed as just allergies when the pattern is persistent, severe, or multi-system. Both HES and EGPA can overlap, but they're not always the same. EGPA is one of the vasculitic conditions, while HES is a broader group of eosinophil-driven syndromes. It can sometimes be hard to tell the difference between them, but fortunately, there are two biologics, mepolizumab and benralizumab, that are both used and shown to be safe and effective in patients with hypereosinophilic syndrome and EGPA. I recognize that approvals may differ in different countries, but at the minimum, the evidence really does show that they work. And then for patients and families, self-advocacy really does matter. So tracking symptoms, asking about treatment side effects and how to manage them can really be helpful in building a coordinated care team, and that really can change the trajectory of the disease. And I really would encourage discussion among specialists, because sometimes people only see one part of the picture. And finally, I want to thank the organizers for asking me to speak here for National Eosinophil Awareness Week. I think it's a great time to review all the different disease states, as well as for patients and families to recognize that the clinicians are here to partner with them. And so I thank the patient advocacy groups for organizing and bringing us here to talk about these conditions. And with that, I'm going to close. I'm happy to answer questions after the fact if they arise.